Okay. It's about to start. Come on. I apologize. Yeah, my laptop, of course, went down. There we go. Perfect. Thank you.
All right. Should I start with the introductions?
Yes, please. That'd be great.
Okay. So Dr. Paul Benfonte is a board-certified orthopedic surgeon. He completed his medical studies from the Uniformed Services University of Health Sciences in Bethesda, Maryland. He completed his orthopedic surgery residency at Eisenhower Army Medical Center at Fort Gordon in Georgia. Dr. Benfonte's fellowship was in pediatric and orthopedics and spinal deformity, which he completed at the Shriners Hospital for Children in Greenville, South Carolina. Dr. Benfonte is a retired colonel in the United States Army. During his military career, he served as the Orthopedic Surgery Program Director and Chief of Orthopedic Surgery at Madigan Army Medical Center, Tacoma, Washington. Dr. Benfonte enjoys all aspects of pediatric orthopedics and has a special interest in sports medicine and foot and ankle reconstruction.
Well, thanks for that introduction. So I'm not used to Teams. I usually use Zoom or something else. So how do I share the screen? Anybody know?
I will come down there and help you.
Carol, okay. Okay, so I assume all you guys are interested in medical school, or that's why you're on here? Yeah, okay. And you're all high school students? Okay.
Yeah, 10th through 12th.
Oh, okay.
There is.
This is Carol.
Hi. Gotta dismiss that. Get out of that. Oh, you're on a.
I don't know what
He's on a MacBook. I don't know how to use them. Oh, here. Right here, that up arrow.
Right, that?
Yep, that's
Open
it.
share train?
Yep. And then you have to choose that.
And
then
allow
allow it. Yeah.
So then what?
And then now you go to what it is that you're trying to share.
This?
Can you guys see?
Can you guys see that?
Yeah, we can see that.
You can see my screen. Okay, because I can't see you anymore. So, okay. Okay, so we'll just, if you have any questions, I can't see you, so just ask me questions. So, I'm not sure if you've talked to, have you guys talked to an orthopedic surgeon before?
Not this year.
Not this year?
Last year we talked to Dr. Phillips.
Dr. Phillips, and he does pediatrics and then specializes in hand surgery. Okay, so what does a pediatric orthopedic surgeon do? So in general, an orthopedic surgeon works on the musculoskeletal system. That's pretty much from the neck down, your arms, legs, spine, everything. It does not include your chest cavity. We get a lot of consults for broken ribs. We don't do that. And it does not include any, skull injuries or anything like that, but pretty much the spine and your appendages. Pediatrics just means we do this in kids, and kids by definition for us is anything from newborn to 18 to 21. So it really encompasses the entire spectrum and actually gets into adult surgery. So why is pediatric orthopedic surgery special? You'll probably hear this as you go through your training at some point, but children are not little adults. Their anatomy is different, their physiology is different. Is it not working?
It's working, but if you could put it in the slideshow, because we're seeing all of your emails.
How do you see my emails?
I don't know.
Don't read my emails. Okay.
We couldn't see it. It's just
okay.
The slides.
Can you still see me though? Because I don't see the camera thingy. Yes. You see my thing. Okay. Yeah. So Peds Ortho, we take into consideration all the things that are specific to kids, and most of this is what we're dealing with is their different anatomy, and by that I mean their tissues are still growing, specifically their growth plates. We need to be especially cognizant of, and we treat different things. Like adults, as we'll see, adults don't have the same conditions that the pediatrics do. So just get an idea of what it takes to be a pediatric orthopedic surgeon. Obviously, you need to complete high school. Then you're going to go to college for 4 years, and you're going to get a BS or a BA. This can really be in anything. It doesn't have to be science. Basically, you're going to go to school. There's going to be some prerequisites you need for medical school. As long as you have those, you can do whatever you want. I think my senior partner was actually a Romance languages major. Another was a history major. I like the sciences a lot, so I did biophysics. I hate like writing papers in English and stuff like that. And then after you graduate from college, you're going to go to a medical school. That's typically 4 years. And then after medical school, you'll go to an orthopedic surgery program. Now it used to be divided into two parts. One was internship, which was technically separate from the residency, but now they're kind of rolled together. So it's a 5-year program in orthopedic surgery. And then once you finish that, then it's usually an additional year for your what's called a fellowship in pediatric orthopedics. Some fellowship programs are more than 1 year. If there's an additional year, usually that's research. Does anybody have any questions about the process of going through training? No, obviously you have to get good grades. There's a lot of other stuff you have to do. Okay.
I don't see any questions.
No question. Okay. So the other question I was asked, well, what is a typical week in pediatric orthopedic surgery? That really depends on your practice, and all the practices are different. As you talk to different doctors and different specialties, the practices are put together differently. We here typically have 1 or 2 OR days, and then the rest is clinic. For pediatric orthopedic surgery, the hit rate, and the hit rate is defined as the number of patients you have to see before you get a surgery out of it, is probably 10 or 15 to 1, or even higher, 20 to 1. So I'll see about 10, 15, 20 patients before somebody actually needs surgery. A lot of my day is reassuring moms and dads that their kids are okay, and then their flat feet, not knees, and bow legs are normal. Whereas if you go to like an adult reconstruction program, those are the people that do total joints. Almost everybody who walks in there needs surgery or will need surgery in the relatively near future. So their hit rates are like 50% or higher. And so that's why we see a lot more clinic than some of the other subspecialties might. In addition to clinic and OR, pretty much every surgeon, every orthopedic surgeon, most doctors are on call. And that call will also vary with your practice. So call usually means you're responsible for every emergency that comes in for a 24-hour period. And we take call 2 to 3 days at a time while still seeing clinic. So we have to fit that in on top of our regular workload. Like I said, it could vary. If you don't want to do call, then don't go into orthopedic surgery. There's a lot of other specialties that don't have call. And then again, this may run into weekends as well. So surgery and orthopedic surgery in general, the subspecialties, you're going to be pretty busy. So the beauty, I know you talked to Dr. Phillips, some of you may remember that last year about hands. Well, he does peds, but specializes in hand. One of the beauties of pediatric orthopedic surgery is that it's a huge scope of practice. When I was in my residency, a lot of my fellow residents were deciding on doing hand or spine or sports or total joint. And to me, this was a relatively limited scope of practice. So you can get, I thought anyway, you get bored pretty quick just replacing hips, day after day after day. In peds, you can pretty much operate anywhere on the body and do just about anything. I'll go through a few cases, but pretty much, spine, anything on the skeleton. You can do sports, specialize in hand, foot and ankle, what's called neuromuscular disorders, which are your kids with cerebral palsy, myelomeningocele, things like that, tumors. You're going to see trauma a lot of, no matter what you do, you're going to see trauma. And then there's congenital abnormalities you can see, like clubfoot and hip dysplasia and things. So the scope of practice in peds orthopedics is huge. And it's one of the things I like because there's so many things you can do, and you don't get bored. Any questions about that before we go on? about
Well,
anything?
we did have one question in the chat, but we might as well just address it with everybody. When you talked about like your normal schedule, an OR day is a day that he's in the operating room doing surgery, and a clinic day is a day that he's in the office seeing patients, and he can see anywhere between, I don't know, 15 patients at the least, up to, I don't know, what's the most you've seen in a day,
Uh,
Dr. Bonfanti?
Over 60. So yeah, 15
Yeah.
wouldn't even be, I wouldn't even call that a clinic. So anywhere
Yeah.
between 25 is low to over 60. And of course, we have PAs that help us out as well.
Yeah, and then what can you tell us about an on-call day? What does that actually mean and what do you do?
So when you're on call, you are responsible for any emergencies that come in. So in our practice, we have a PA that will take first call, meaning that they'll kind of answer the calls and kind of triage for us, which was like, okay, how important is this? And then they'll get it worked up for us, and then we'll decide what we need to do to treat it. So like a typical thing may be we have a 5-year-old with an elbow fracture. So not every elbow fracture needs to go to surgery right away, but some do. And you know, the ones that do, we need to make time in our schedule or do it at night after clinic or after OR to take care of that emergency. And it can be hit or miss. There are some lucky call nights where you may not have to go in, and there are other nights where you're going to be up all night taking care of things. Does that answer?
I think
Okay.
so.
That's good. Thank you.
Okay. So I just have a few, kind of generalized things that pediatric orthopedics take care of, and we'll just kind of go through those, and feel free to answer or ask any questions anywhere through this. These are very general conditions. Literally, there's books written about every single one, and every single one has about 100 different variants. So one of the things you always hear about in kids is scoliosis, which is a sideways curve of the spine. This can occur in anywhere from babies to adolescents. The most common one we see is in adolescents. Adolescent idiopathic scoliosis is the most common type of scoliosis we see. Idiopathic just means we don't know what causes it, it just happens. And treatment can be anything from watching it to see if it gets, if you have a really mild curve, you'll watch it to see if it gets worse, to potentially bracing it, to potentially doing surgery on it. And there's a lot of factors that go into that: the age of the patient, the severity of the curve, that kind of thing. I don't know if when I looked at the group here, it looks like you're all girls. You probably know somebody who has scoliosis. It's most common in females by far. So some of the things you might see in kids with scoliosis, especially when they're wearing tighter clothes, is that you may notice that their shoulders are uneven, or they might have a bump or a prop. Can you hear me?
I had it though. So if I want to buy my nail, why can't I buy my nail? I'm already sick. What's gonna happen?
Can you guys, let's try to mute your mics. So thank you.
So yeah, some of the things you may see: uneven shoulders, or a shoulder blade that appears more prominent. You might have what's called a waist shift, where it looks like your hips are shifted to one side more than the other. You might notice rib cage sticking out, or your breasts are uneven, or a prominence on one side of the back when you bend forward. Those are all signs, and most of you guys, we don't do it, but most of the kids get screened by their pediatricians, and those are the things they're checking for, and then they'll send them to us. So what you see there on the top right is a typical brace that you'll wear. And then if you fail brace treatment, you get the screws up and down your spine like that. Any questions about scoliosis? Okay. Foot deformity is very common, and one of the most common ones we'll see is clubfoot. That's a picture of clubfoot there because it looks like a club. We don't know what causes this. This occurs in about 1 in every 1,000 births. Many times this is picked up on your prenatal ultrasounds. You get those at about 20 weeks of gestation, and they can usually pick this up. Of course, there's nothing we can do about it until the baby's born. And once they're born, we initiate casting, and that'll be on the next slide. But basically, we don't know what causes this. It's all the tissues are contracted. on the inside of the foot and pulled the foot to the inside like that. We used to do surgery on every one of these feet until Dr. Ponseti came up with his casting protocol, which is a gradual casting correction of the foot. And you can see that's the typical stages we go through to cast the foot. And then most of the kids will also need a very small surgery to lengthen their heel cord and then bracing after that. But Dr. Ponseti revolutionized the treatment of clubfoot. And then we tell parents with babies with clubfoot that, you know, they will essentially be normal. They'll have a functional foot. They're going to walk on time. They're going to play sports. A lot of new parents are very worried about this condition when they see it. Any questions on club feet? You're probably too young, but there was a figure skater named Christy Yamaguchi who had a club foot, and she was I think she won the gold in figure skating.
I didn't know she had a club foot. That's cool.
Yeah. Mm-hmm. Another common condition we see is it affects the hips. It's called hip dysplasia. Dysplasia just means that the hip isn't developing normally. It has a tendency to develop abnormally and want to come out of the socket. And you can see that the hip on the left there is actually the right hip. The one to your left, how small that little hip ball is there and how it's not fully seated in the socket. So we treat those that's a common thing we treat. Many of them can be treated just with a brace when they're born, but if this isn't recognized or caught, then it may need extensive surgery as the child grows. Risk factors for this: firstborn, female, kids that are breech, and anybody with a positive family history of it. Any questions on that one? I don't think I have any really gross things. I was thinking of putting them in there, but I didn't. So that's the typical brace the kids wear. It's called the Pavlik harness. And you diagnose this with an ultrasound when they're newborn. And this is just a picture of an ultrasound on the left.
Dr. Benfanti, we have a question going back to the club foot.
Okay.
Why would you choose casting over surgery?
That's a great question. So in general, we like to be as minimally invasive as possible. And I did not put the pictures of surgery in this presentation, but the surgery for clubfoot was basically a controlled amputation. You would have to open up the foot and just about release and lengthen everything in the foot, except for a couple tendons and stuff in the back. And all of those feet ended up stiff. And the results from casting were just markedly better with minimal surgery. The surgery for after we finish casting these, literally is the incision is about 3 millimeters in length, and it takes 30 seconds versus 2 hours of extensive foot surgery. So the results are better, basically, much better with the casting. Just before Dr. Ponseti invented it, nobody had tried it, or nobody was successful with it. There's a very specific pattern you have to follow to get the reduction of the foot. So we also see sports. So this basically includes everything the adults see. So basically, your growth plates close in general when your girls are about 14 and boys are about 16. The other way to estimate it is about 2 years after a girl starts their periods, they're done growing. So if you have your periods at age 9, you're done growing by 11. And at that point, once your growth plates are closed, technically you're an adult. So we have to be able to do all the sports surgery that the adults do in addition to the surgery that's required for the younger kids. And ACLs are a very common injury. I wouldn't be surprised if somebody in the audience has had one already, an ACL reconstruction. But a lot when the kids are younger, you really don't want to cross the growth plates with your graft, because what you do is you have to make a new ACL, and you have to put this graft where the old ACL was, and you have to drill through the bone to do that. Well, if you drill through the growth plates too, you can cause them to close early, and if they close early, you can get all kinds of problems like a short leg or what's called an angular deformity, where the foot or the knee twisted inwards or outwards. So there's different techniques of doing this where you can spare the physis or the growth plate. Any questions on that? This goes for foot surgery, shoulder surgery, anything where you're around the joint, hip surgery. Okay. The other thing we see in clinic a lot are kids with knock knees and bow legs. So knock knees are the ones on the left where the knees touch before the feet do, and the bow legs are on the right where the knees are far out and the ankles are touching. Now, when I said that I see about 20 patients before I pick one up for surgery, the reason is a lot of kids, this is normal in the development of a lot of children. So kids will go through a bow-legged stage at about 18 months of age, and then they'll go through a knock-kneed stage about 3 or 4. And many parents are concerned about that, and they come in and we look at them and we say, okay, everything's fine. You don't need anything, but of course that takes up an appointment. So that's why we don't sign up everybody for surgery, because a lot of this stuff will get better on its own. There is treatment for these things if they persist outside of a certain age or if the deformity is severe. And one of the things that we do is, well, it's probably been around for at least 20 years or more now, is called what's called hemiepiphysiodesis. That just means we're going to shut down half of the growth plate. So on this picture, what you'll see there are screws and a plate on the outside of those knees. What's that's doing is slowing down the growth plate on the half of the knee where the plate is. On the other half, it's growing normal, and over time, the bow legs corrects itself. And when it does, we go back in and take out the plates and screws. It's a very powerful surgery. It's very minimally invasive. The results are good. That's one we do fairly frequently. And that can be done, and again, we do that mostly around the knee, but it can also be done around the ankle and occasionally around the hip. Hand surgery, I know Dr. Phillips probably went over a couple of these things. Just some really basic ones. I think one of the most interesting hand surgeries, I don't do it, but is making a thumb. It's called a pollicization. So you can see the picture on the left there. That kid's thumb is just floating there. It's totally useless. So that's going to come off. But your hand is almost useless without a thumb. So there's a surgery called pollicization, or pollicis means thumb, is making a thumb. So you see on the picture on the right, they took his index finger and made it into a thumb. Very extensive procedure that works pretty well.
I think there was a question about the last surgery. Someone asked, does that mean the patient might not grow to maximum height if you do that surgery? Not about the thumb, but the one before.
Right,
that.
yeah, that's a good question as well. So that's a good question. So if we let them grow, would they be taller? Probably not. Does it mean their bone? So let's take that in 2 parts. Is the bone going to grow as much as it possibly could? No, we're going to slow it down on one side. But the other way to think about it is, if we let it grow and didn't do anything, they would have such bad knock knees or bow legs that length in their bones wouldn't matter, because they wouldn't have any height anyway, because their knees would be bent, if that makes sense. So if you straighten the legs, they actually become straighter or are taller. So even though we're going to take a little bit of ultimate length from the bone, they're going to be taller because their legs are straighter. It's like in the scoliosis surgery. Are we taking away some growth in the spine when we do that surgery? Yes. But by straightening it, we often add anywhere from 2 or 3 inches or more to their height, because the spine is now straight. Okay, I hope that answered your question. So another common hand surgery we'll do is called syndactyly, and that's just where the fingers are joined together. That's another pretty common condition. You see it in every 2,000-3,000 children. And it can be simple. It could just be skin, or it could be skin and bone, or bone or muscle, tendons, all that stuff can be shared. The most common type is simple, which means it's really just skin. And you might be looking at that operative picture and wonder why there's so many cuts around there. Because it looks like all you have to do is cut down the middle and close it up. But you can't do that. I mean, one experiment you can do is take two pencils and tape them together, then cut the tape between the pencils and see if you have enough tape to cover the pencils when you're done. You don't. And so you end up doing these weird, what are called flaps. You have to cut the skin in a certain way so it overlaps and covers more area. And most of these will need a skin graft, which means taking skin from somewhere else, most commonly the butt or the groin, to fill in areas that weren't covered. So it looks like a simple thing, like, hey, just cut it in the middle and it'll be okay, but it's pretty extensive as well. In addition to fingers being stuck together, we see a lot of extra fingers. It's called polydactyly, or multiple fingers. And the most common type is extra pinkies, but you can also have extra thumbs. And that could be anywhere from what we call little nubbin, which sometimes you can just tie off in the nursery and it falls off, to like a completely normal extra finger that you wouldn't know was extra unless you counted. And so basically we end up, we call doing a reconstruction. We end up taking it off and reconstructing the finger. Interestingly, there are families that keep them because it runs in the family. So I've had a couple of patients over the years that they'll come in for an extra finger because the pediatrician sent them in, and I'm like, okay, do you guys want to take it off? Like, no, grandma's got 6 fingers, we're keeping it. So, they don't have to come off. It's more of a cosmetic thing. So the other thing, like I said, if you have any questions, just ask. If the other thing you're going to see a lot of is trauma. Tons of trauma. A day doesn't go by where we don't have several fractures. Things we hate as pediatric orthopedic surgeons, we do not like trampolines, trampoline parks, bounce houses, hoverboards, rollerblades, scooters, skating parties. All those things are horrible. The worst
Dr.
time to be.
Benfante,
Yes.
we have a question about polydactyl. Does it affect both hands or just one at a time usually?
Yeah, that's a good question too. So most of it is bilateral, meaning most of the kids have an extra finger on both hands, but it can be just one.
And then how long do the surgeries, like the one involving the syndactyly, take? Like how long would that surgery be?
Yeah, so separating the fingers is probably about 2 hours, and it's all surgeon dependent. There are, some people are faster than others. The syndactyles, like I said, it's very meticulous. It often involves a skin graft, so that's probably 2 hours. The pollicization, or making a thumb, is more like 4 hours. What else did we see there? Oh, the extra toes, it depends on how involved it is. That could be anywhere from literally 3 minutes to, an hour or so. So yeah, I was saying the worst time to be on call is is Christmas morning.
Wait, one more question.
Oh yeah, go ahead.
Is there such thing as like a thumb transplant? Like, could you give an extra thumb to somebody that needed a thumb?
A legit question.
So yeah, so you can't. So we in orthopedics we don't really take live tissue from one person to another. That's a great question, because they do that in other specialties. Like you'll get a liver transplant or a heart transplant or a lung transplant. We don't do that because of your reactivity. We do use tissue from other people, but it's been processed. It's been either freeze dried or treated in such a way that we have the basic skeleton, we have the collagen, we have the tendon, but there are no live cells in it. So in ACL reconstructions, we can use somebody's hamstring or somebody else's other tissue to make a new ACL. But the beauty of that is there's no reactivity. They don't have to be on medicines to prevent rejection after that, because there's no live cells. Now, as far as transplanting a thumb, we wouldn't take one from another, but if you get your thumb cut off, they can replant it. So that would be hand surgery, and specifically microvascular, and that's extremely tedious to do. The good thing about pediatrics is that the results of replanting fingers in kids is much better than adults. And there are times in trauma where you might cut their fingers off, and in an adult you'd say just throw them out or they'll never live. But in kids, it's almost worth reattaching it because so many times they have so much regenerative capability that they survive. So that's another good thing about kids is they heal just about everything. Yeah, so Christmas Day, don't be on that day if you can help it, because every tubby kid's opening up their hoverboard and they're falling off and they're breaking their legs and their arms and stuff. I was on about 2 or 3 years ago, and by noon there were 6 fractures in the ER just from hoverboards. So you probably don't have any kids yet, but don't get them a hoverboard. So things
another question is, with all the newest advancements in technology, like, are any of these procedures becoming faster or more effective? Like, what's kind of new in technology and orthopedic surgery?
And well, in orthopedic surgery in general, I can talk a little bit about peds. There's been a lot of advances over the years, and things we take for granted. And we can go back as far as just the invention of antibiotics and fluoro machines. In the old, you see how these pins are placed in the elbow there? Well, in the old days, or nowadays, we have a little machine we can bring in called a C-arm or a fluoro. We can do this live. Back when I first started, which wasn't that long ago, 25 years ago, they didn't have it, and you'd actually have to get plain x-rays and wait for them to get developed, and you'd be going back and forth and back and forth and back and forth. So that's one huge advance there. There are always, the other thing that's been a huge advance in orthopedics in general is very specific instruments and implants. So when I first started, there was one company. You had pretty much a plate and screws to fix just about anything around the body, the same set. It's like, get the Synthes set. Nowadays, there's 20 different manufacturers. They have what are called anatomic specific plates, which are conformed to the bones themselves, and they have what are called locking screws, which lock to the plate and the bone. They have things made out of titanium, which is better, what we call modulus of elasticity. Just tons and tons of things are changing all the time. Different approaches. Just I had my hip replaced 3 weeks ago. When I was in residency, that would be like a 2-week stay in the hospital and rehab and all that. It was done in an ambulatory surgery center, and I was out walking the same day. So tremendous advances being made all the time. Bone graft. One of the jobs of what's called the first year resident, or PGY2, used to be to take bone graft from the hip. That we used to be able to do that with our eyes closed. We open up the pelvic, the crest, scoop out some bone graft to pack it into fractures to help them heal. And nowadays it comes in a bag, so you don't have to do that anymore. You just pack it in, and it works fine. So there's just been a tremendous amount of advances over the years, and it's kind of exciting to see what your generation is going to see. I tease the residents. Back in the day, we didn't have cell phones. We had a pager, so we had to pull over on the street to answer a page. But now you got a cell phone. You can have the x-rays texted to your cell phone, and you can also look up the treatment on your phone, which more than half the residents do. And you can do all their orders and stuff on your phone. So a lot of advances have occurred very rapidly over the past 20 years or so. Yeah, you can do a several hour talk on that alone. Let's see, just going on, other trauma, femur fractures, we see a ton of those, and those can be treated any number of ways. A lot of it depends on the patient's age. If you're a baby, you're going to get what's called a spica cast, you see down here. You can get flexible nails. You notice in here that they avoid the growth plates. So this is one way to avoid the growth plates. And I don't have a picture, but in adults, you'll just be a solid rod right down the center of the canal there. That's another place, advancing. Speaking of that, these flexible nails have probably been around for 15 years or so. Before that, the kids would be in traction on the floor. You put them in traction for 2 or 3 weeks until the bone got sticky, and then you put them into a cast. And by sticky means starting to heal so it wouldn't fall apart. Lots and lots of fractures of the forearm. Some you can do closed reduction, which means you just have to push it back in place and put a cast on it. Some need to be opened up and plated. Some could be treated with rods down the middle. So again, lots of different ways to treat things, different advances in technology. I think that just had a very small or representative group of surgeries there. What other questions? Do you have any questions specifically about, I mean, anything, medical school? What do I do to get in? What's it like? None?
I know, they're so quiet now.
Did I scare you? Who wants to be an orthopedic surgeon?
I know the suburban medical explorers have been really excited to talk about pediatrics this year, so we'll give them another second to type
Okay.
or say their question.
How long does it take to become a pediatrician?
So a pediatrician, I think, is only I think it's a 3-year residency. And that pediatrician is basically a general practitioner that specializes in the medical aspect of pediatrics. So they don't do any surgery. They're more of a general medicine person that treats kids. And I think a lot of them go on to do fellowships too. So you'll have an adolescent medicine or a sports medicine or an allergist. A lot of them go on to fellowships afterwards.
And you mentioned that you don't like writing stuff for English, but biology also requires a lot of writing. Did you feel that was different?
I don't remember writing a lot in biology. My brain is geared towards science for some reason. I just was not good at the literature stuff, English. That just wasn't me.
Yeah. And what was your experience like in med school?
So I went to the Uniformed Services Medical School right down the road in Bethesda, Maryland, across from NIH, and that was a military medical school. So my medical school experience is probably different than usual because I was actually active duty at the time, so we had active duty responsibilities to do as well. But it basically, your first couple of years were classroom oriented, and then the third and fourth years were rotations in the hospital. Now, this was 30 plus years ago, and I think that model has changed, and some of the students may know better, but I think they're trying to combine more of the clinical and academic stuff at the same time. So the kind of the model has changed for medical schools now.
What kind of made you choose orthopedics, and what made you choose pediatrics within orthopedics? Like, what came first, the desire for pediatrics or the desire for orthopedics? How did you come to that?
Yeah. So when I was growing up, I loved my pediatrician. He was a great old man, very smart, very gentle, very kind, very knowledgeable. So I actually went to medical school thinking I was going to be a pediatrician. And then I did my pediatrics rotation, and I did it at Walter Reed and Bethesda Naval Hospital. And it really, I mean, just a lot of very sick kids that didn't do well. And I think that turned me off to pediatrics. And then I did some surgery rotations, and I liked surgery. And then I did my orthopedic surgery rotation. I said, oh yeah, this fits me much better. And then in my third year of residency, I did a pediatric orthopedic rotation, and then just everything clicked. Like, this is everything I want to do. I want to work with kids. I get to do awesome surgery. The vast majority of our patients do well. There's a handful of kids that get some bad tumors, but we don't deal with that. So healthy population, kids do well, awesome surgery. So that's kind of how I decided on peds ortho.
We
And
had
then,
Dr. Perno last month and he kind of said the same thing. He was like, wait till you do your rotations there to see what you like. Cause you may, yeah, like you said, you went in thinking, I want to be a pediatrician, but then maybe you did the OBGYN rotation. And you're
Right.
like, I really love OBGYN. So
Yeah, that
just
didn't
go in
happen
with an
either.
open mind.
Yeah, I went through med school and it was almost like I was checking things off like, nope, nope, nope.
Yeah.
Yeah, so, but other people are like, they loved everything and they have a hard time
Yeah.
deciding.
now, do you get break days during the week?
For what, med school or for here?
Caitlin, did you mean during med school or did you mean during the work week?
So yeah, I'll do both. So med school, we had a note-taking service. So I was famous for not going to class and just just going off of the notes. I shouldn't say this, but you know, C equals MD. And so you go to class as much as you want. I shouldn't say that. You should go to class. You guys go to class when you go to med school.
Don't promote bad habits.
Yes. So and here we get about one admin day off where we can take care of stuff you need to take care of. But everybody learns differently. Everybody, you may be a visual learner, you may be an auditory learner, you may have to read things 10 times over, you may have to write it down. You'll figure out how to do it when you're in med school. And I think most of them offer, or you can figure out how to do it. For me, it didn't make sense to sit in class. I like just to go over the notes. That's just the way my brain worked. But other people had to go to every class and be there. So you have the option.
Yeah. What's the process of matching for your specialty? Like, what if you decide you want to go into the specialty and then you don't match with the specialty that you want at first?
Yeah, so things have changed. So you may have to talk to somebody who's been out less than me, but so if you don't match, they have the National Match Day, and if you don't match in a specialty, usually you default to a different subspecialty. Like I had a friend of mine who wanted ophthalmology, he didn't match and ended up in radiology. So you'll kind of have a rank list, or if you like, I am doing nothing but orthopedics, you just take a year off and do research or something else to make your application better, and then you reapply again. And a lot of people will do that. You'll see a lot of people have been out for 2 years or 3 years. They've done a ton of research, and that bolsters their application enough where now they're more competitive and they can get in. So if you're thinking of medical school, it's not just the grades, although the grades are very important. And it's basically a game. It's checking a lot of boxes. And so if you can get involved in research somehow, that's great. If you do something outside of, they don't want people who are only interested in book learning either. If you have other interests that you excel in, it could be sports, it could be in music. They like to see people who have humanitarian interests, like you work with the poor, you work with children, that kind of thing. All that stuff is important and helps your application.
Could it help to establish a relationship with the program that you're trying to match to ahead of time?
It is, but it's not easy. It really depends where you live, and it depends on the program. So, and you probably wouldn't be able to do that until you're at least in college. High school, I don't think that's going to happen, but college, you may be able to hook up with a certain department and work with the group who's doing research. That's what a lot of people do.
So there's some strategies to try and help match, where you want to. And what sort of cases or surgeries did you do during your surgery rotations?
So when you go to medical school, you're going to go through pretty much all the subspecialties. So, I did general surgery, thoracic surgery, cardiovascular surgery, orthopedic surgery, OBGYN, gynonc, all that stuff. So And it depends on where you are. I was at Walter Reed and Bethesda Naval Hospital at the time. Now they're combined or something, but so pretty much everything. That doesn't mean you're going to do anything. You may just, most of the time you're going to be sitting there and watching as a med student. And so the other thing you're going to need to develop is patience. That's huge. I remember my first day at Walter Reed as a third-year medical student in the general surgery, which is extremely, at that time, was very competitive and kind of a mean program. I was like, we were doing this big liver resection, and I was like 3 people deep on like 3 stools, just watching, and I couldn't see anything. I just stood there for 9 hours. I'm like, why am I here? So you're going to have days like that, but again, that's what you're going to go through. You're not going to be coddled to. You're there to work, you're there to learn, and it's not about you. That sounds horribly blunt. That's the way it is.
Oh, I think that's what people need to hear. So thank you.
Yeah.
And then it's kind of difficult to keep up with all of the new medicine and technology and procedures. How do you kind of determine if it's better to use like the way you were trained, the old school kind of method, or if you should, start using that new cutting edge method? Like, how do you determine what's best?
Yeah, so the best thing you can do is learn how to think and don't just listen to everything that comes around that sounds new and wonderful. We have a saying, it's like, don't be the first on the bandwagon and don't be the last. So basically, I want to see something that's been tested. I want to see some studies that have been out with at least some decent 2 to 5 year follow-up before I'm going to start using it. But at the same time, I'm not going to stick with the same old treatment that's been, out of date forever. Like I wouldn't keep operating on club feet, the old-fashioned way when something new has clearly surpassed that. So don't be the first and don't be the last, and think about it. You do some critical thinking on your own.
And kind of going back to med school and stuff, is it helpful to have a mentor? And if so, how do you suggest identifying one?
So a lot of med schools will provide you a mentor. They'll have like somebody you'll check in with on a monthly basis or a weekly basis, that kind of thing. If they don't provide that, then identify with somebody that you like, that you want to model after, and just kind of hang out with them and ask them questions and everything, and assuming they're okay with that.
They're all great questions, guys. Any other questions?
Oh, yeah. Was there another profession or subspecialty in peds that you were interested in pursuing? Like, what if you didn't match to ortho?
Yeah, that's a good question.
What
Yeah,
would you have done?
Yeah, so if I didn't match to ortho, so like I said, orthopedics is a huge time commitment. It's a calling. You're pretty much on 24/7. If I didn't match in orthopedics, I was going to pick something that suited a lot more of a lifestyle. And so I would probably have done either ER, which is shift work, which I think would be good. Or I was thinking of radiology, where I just kind of sit in the office and hang out for 8 hours and then go home. Or nowadays you can do it in your underwear at home. So it was either ortho or something that was going to be more lifestyle friendly. Although you probably could do ortho in your underwear if you wanted.
I don't know.
Tough crowd.
Surgery.
Okay.
Anybody else? These are great questions. I love it.
So I have a question. When
Yeah.
doing med school in the military, what does that path look like? You join the service first and then you get into med school, or you join the service like with the intention of going to med school? Like, how
Right.
does that work?
So there's a couple ways to do it. If any of you are looking at ways to pay for college, or med school. So I was on an ROTC scholarship for college. So I owed them, I think, 4 years when I finished college anyway. Now, med school can be paid for by the military in 2 ways. One is through the program I went through the Uniformed Services Medical School. And basically, you're on active duty. They pay for everything. You're paid as a second lieutenant. You have absolutely no debt, money-wise, going into there, but you owe them 7 years of service after medical school. Now, that gets a little confusing because it's not 7 years right away. It kind of added on to your residency and everything. So long story short, I ended up spending 18 years in the Army before my commitment was paid up. But that's one way to do it if you can't afford it. The other way that the government will pay for your medical school, if you're looking for that, is called an HPSP scholarship. And I can't remember what it stands for. It's like Health Physician Service Provider, something like that, HPSP. And basically, they'll pay for your med school, but you have to get into med school first. So you'll apply to med school out of college, you'll get in and go, okay, look, I got into, somewhere. And then you'll apply to the Army and say, will you pay for me? And they will. And the commitment's much less. The commitment there is 4 years. And so a lot of people would do that way. If you're looking for some way to pay for med school, the Army's not a bad way to do it. You'll get good experience coming out of the military.
So there's some lifestyle questions here too. So do you have any advice to not get overwhelmed about this career path? Because you constantly hear about how cutthroat a career in medicine is.
Yeah.
Is it just like that in the beginning, but then towards the middle and end of your career, does it get easier? Like how stressful is it really?
So I have nothing to compare it to because that's what I did. I can't say, my other life I lived this way. Pretty much it is stressful. It is very competitive, so it's very cutthroat from start to finish, especially all the way. As you get more and more along the path, it gets tougher and tougher. Getting into college is going to be competitive, okay, but then it narrows down. I think, I went to a relatively small school. In our freshman class, well over 100 students declared that they were pre-med. When it came time to apply to med school, there was only 6 left. And of the 6 of us that applied, only 3 got in. And so that narrows that down. And then you get into med school and everybody there is as smarter than you. And then, so the competition increases. And then when you're applying to residency, especially the ones that are in demand, and orthopedic surgery is always one of the top ones that's most competitive. Like I said, it's a game. You're going to do stuff. You're like, why am I doing this? And you just got to do it. It's very competitive. Now, once you're out, once you're done training, then you can make some choices. Okay. You can decide after med school, do I want to do a surgical program because of the lifestyle? I can do something else where it's not as busy. Or once you're in orthopedics, you can pick something that's not as intense. Somebody like you can pick hand surgery without the microsurgery component. You can just do, work out of an ambulatory surgery center. There's things you can do afterwards, but in general, it is stressful. That's why doctors are reimbursed fairly well, but that's why they also burn out. So I think it's important to have clearly important to have a balance. You have to have something outside of medicine to balance your life, whether that's your faith or some hobbies or your partner or whatever. You need something to do outside of medicine.
So do you still get time to spend with your family and do personal stuff? Maybe you can talk about your path right now with your changes coming up.
Yeah, so my kids are grown and having their own kids now. So I'm a grandpa. So my kids are out of the house. But as I'm winding down, my faith has gotten a lot more important to me as I've gotten older. So I'm actually on the path to becoming a deacon in the Catholic Church, which is a 5-year program. And I'm actually doing my master's in theology right now on top of everything else. So it's talk about stress. Yeah, so it's important to have other things outside of medicine. Too many people are defined by what they do, and that's really not the important thing. It should be your job. You should do it well. You should give everything to it, but it shouldn't be, who you are. You should be more than that.
And are there any moral dilemmas or ethical issues you faced in the medical field?
We've had some tough patients as far as, as orthopedics, we also see a lot of what's called non-accidental trauma or child abuse. Those are kind of tough things to deal with. Whether to operate on somebody, a lot of the decisions are fairly clear cut. The other thing, this is one of my mentors told me this when I was first starting, and I didn't understand at the time. He says probably the best thing about medicine is your relationship with your patients. And I was like a PGY2 resident. I'm thinking, yeah, I just want to operate. But as time has gone on, what I really enjoy most is the relationship with my patients. I've had some patients I've seen for years. I still stay in touch with a few of them as they've gotten older. So as far as moral dilemmas, not a ton, but I just want to throw out that it's more than just operating and seeing clinic. You try and connect with your patients and have a relationship, and it's not going to happen with everyone. You can't have a relationship with everyone, obviously, but kind of just try and be human at the same time.
And then when you are on call, what does that mean? Like, are you being called? Are you like going to the hospital? And then are you on call 24/7?
Yeah. So when you're on call, you are on call 24/7. And like we said, we do that 2 or 3 days in a row. We used to do it 4 days in a row, but that was incredible. So our PA will take, like you say, the ER has an emergency. They'll call our PA and say, hey, we got a kid with a broken leg. The PA will kind of work it up and call us. We'll say, okay, we need to fix it. And we'll have to go in and fix it. And so that's 24 hours a day. It could be, if you're lucky, you're done at 10 at night. If you're not, you're doing it at 2 in the morning, and then you finish and you go start clinic again. So it's not for everybody. My wife's she was a child psychiatrist. We were in med school together, and she realized very quickly that surgery wasn't for her. She would literally either go and hide or sleep when she was on call. And she goes, I know I can't do it. It's just not for me. So if you're not somebody that can stay up all night or, works well under pressure, or when you're tired, there's other things you can do too.
Well, and I just wanted to mention too, not all group practices take call at the hospital. So, especially adult orthopedics, because there's just so many. Some may only take, so when we say Q7, that means like you take 1 day of call every 7 days or something like that. So not all surgeons take call 4 days in a row. They could literally just take one day of call every 7 days. Every group practice kind of defines their own rules of how they kind of dish out the call. And if your practice doesn't is not on a trauma service, their call might not be going into the hospital. It might be just getting phone calls from the ER like, hey, I've got this patient that has knee pain. What do you want me to do with them? Oh, have them call my office. I'll see them tomorrow. And you're never actually going in. So it just really depends on your relationship with the hospital as to what type of call you're taking, because some call is just, like the after hours calls from the patients that you're returning. You're not actually going into the hospital. It just depends. Every group is different.
It depends on your practice. Yeah. If you're orthopedics, you're probably going to do you're going to do some trauma. A lot of it depends on group size too. So my friend is a shoulder surgeon down in Sarasota. Huge group, like 50 guys. And so he's on call every 50th day. So that's nothing. And then in their practice, once they reach, I think 55 or 58, they can opt out of call. So at some point he won't have to do it anymore. In the smaller practices like ours, there's only 7 of us. All of us have to take call, or it's just overwhelming. So there is some control there. And there are some ways you can make that less severe.
Yeah, like for example, we have a doctor that we are talking to that lives in Montana, and he shares his call with a group of adult orthopedic surgeons. So there's like 12 of them. So he isn't the only, so he's the only pediatric orthopedic surgeon in the group, but he doesn't have to take it as regularly because he shares it with a bunch of other people. So it just really depends on the group that you're part of and what their rules are.
Yeah, but he takes because
Yeah, I know
he's
there's
the
a bunch in there.
pediatric guy. Anything pediatric, they dump on him anyway. So it's like he's on all the time. So what are you guys interested in? Anybody interested in a certain area already, or just in general about medicine, being a doctor?
Got a neurology in there.
Oh, neurology, yep.
I feel like everybody wants to be a neurosurgeon.
Oh gosh, no.
That's always in medical
Yeah,
explorers.
oh, yeah, really, really?
Neurosurgeon.
Okay, yeah, those guys are crazy. That is everything we talked about. That's a 7-year residency, and then it's more fellowship after that. So I have a tremendous respect for the neurosurgeons. I don't know how they do it. There's things I can operate on. Like I don't mind operating on hands and arms, but I can't operate on a head. There's something about that, like the face. No, I can't do that. So before you decide on neurosurgery, do a rotation there and see what that's about.
Let's see, we got adolescent peds, orthopedics, dermatology.
Oh, perfect. Derm is awesome. Derm is
Especially
super
down here in
competitive.
Florida.
Oh, but yeah. Oh, yeah. Yeah. What? It's not a racket, but it's like.
It could
I
be
make
down
fun
here.
of them
Yeah.
because, like, I think you do medicine. Then I think I want to say it's a 3-year. Maybe you guys know 3-year fellowship or something. But it's sweet. There's no emergencies in derm for the most part. 90% of your stuff is either acne or like brown spots. And you sit there with your can of nitrous oxide or liquid nitrogen and not nitrous oxide, liquid nitrogen, and just zap people. At least that's the way I see it. But
That's hysterical. Yeah.
Derm would be
a lot of older people down here. I think you'd have to be like geriatrics as well.
Yeah, it'd be a great lifestyle choice. It'd be a good one for.
Right.
But yeah, no call.
Let's see. We got pathology.
Pathology, awesome. If you don't like people, that's great. Two of my friends are went into pathology when I was in residency. Both funny guys, and they're like, "We're going into path because we don't want to deal with patients."
I mean, yeah. If you know that, then yeah.
Those guys, a lot of learning in path, a lot of book learning and tests, and interesting stuff.
Let's see, ophthalmology.
Very competitive and extremely subspecialized. I mean, like I just do like the retina, or I just do cornea, or it's amazing. All good specialties.
Yeah, immunology, anesthesiology.
That's a good one too. A lot of good friends are anesthesiologists. Again, most of it is a good lifestyle. They work in shifts, so you can plan your life. I don't think there's call. At least in the way most of these are set up, they have shifts. So you might have a week where you take the night shift, but you can plan around that. You're not working 24 hours for the most part. And a lot of the places have CRNAs, which are nurse anesthetists, which get everything ready for you, get the patients to sleep or set up or do the blocks, and you just kind of go between 2 or 3 rooms and supervise the CRNAs. So that's another awesome specialty to consider.
These are all great. Anybody else want to share or have any questions? Okay,
Okay.
that's great. I was just in there personally because my daughter just had surgery last Thursday on her elbow. She got a screw put in by Dr.
really?
Phillips.
Oh, good man.
I chose him because I went to Texas A&M and he is a fellow Aggie. So I had the choice
Okay.
between you or him, and I'm sorry I had to choose him because he's the
No,
Aggie.
I would have chosen him too. He's the hand guy. So
Yeah, both equally great. So
Yeah.
yeah, PEDS is definitely a great pathway for everybody. So we appreciate your time, Dr.
well,
Benfanti.
thank you. Pleasure talking to you guys. Good luck. If you have any questions, feel free to email us or me or
Yeah.
whatever. Happy to talk
Yeah,
to you.
we can
Especially if
definitely
you have anything
connect.
about the military concerns.
Yeah,
Anybody's interested in that.
I love that that was your pathway. That's a
Yeah.
different one. I don't think we've had that before. So thank you
Yeah.
for sharing.
Yeah.
So yeah, everybody, thank you guys for joining, and Dr. Benfanti for speaking, and everybody have happy holidays and enjoy your
Thanks.
hopefully winter break, and we will see you next month.
Great. Merry Christmas, guys.
Yes, bye-bye.
Bye-bye.
Thank you.
Thanks.
Thanks,
You're
Kate.
welcome.
Bye.
Bye-bye.
Thank you.